the first session of Maili in Pakistan, and we are very grateful to you for being with us.
Thank you.
Imagine please, and we are luckiest enough, sir हमारे साथ हैं, Professor Azim Jahangir, to grace the session. Sir please, Maili का first session in Pakistan. Sir, thank you.
आपने लेना माशाल्लाह क्या चाहिए मैं क्या लड़की वाला भी तरफ से
सर साथ ही सर यस
थैंक यू
सब लोगों का एक ग्रुप फोटो
one more thank you
Thank you very much. Thank you.
and Dr. Amin is now Saad.
Thank you. Do we have our model?
Yeah.
Brilliant. We have many models here. Fantastic. Not only one model. Okay, I mean, good luck. Thank you very much. Thank you. Thank you for coming. Very good to see you again. Thank you. Thank you. Hyaluronic acid filler that Sinclair had just introduced. If I am to sum it up, and we're going to talk about it more in my presentation later on during the day in the conference, but what differentiates Maili than any other filler is that it doesn't have oxygen. What does that mean? It means that during the mixing they managed to take all the oxygen out. So it gives us better force, easier to inject, and we need less volume, and have more projection. So we need less. If I want to do cheeks, I need less than what I would need to use in any other with any other fillers. It comes in different size, different lines. Extreme, volume, defined, precise. Precise is the most flowy one. Extreme is the biggest one and the hardest one, and accordingly you decide. Personally, when I'm with people, with doctors like you, I'm not here to tell you which one goes where. At the end of the day, sometimes you would use something with huge particles or something very viscous in the tear trough, depending on your technique. So it's completely up to you. The box is very cool, and it's very exciting because it comes in 4 syringes in each box. You can see how classy it looks compared to other fillers, and in a bit we'll all get to inject. Right, let's start off by analyzing the face. What's your name?
what's your name
Ruxana. Ruxana, are you fit and healthy? Do you have any health problems?
Yes.
No? You're not on any kind of regular medications or tablets?
No.
Perfect. So tell me, what's bothering you and what would you like us to do?
आपको क्या चीज़ परेशान करती है, क्या है तो इसको ही करें.
ये चीज
Okay.
Laughter lines.
ये ऐसे और ये यहाँ
Jaw lines? What about under your eyes?
आई के नीचे का.
और यहाँ wrinkles
Wrinkles, okay.
और ये lines.
एज कितनी है आपकी?
40. और ये मेकअप के दौरान ये बड़ी फील होती है जब ये बिल्कुल वाज़ेह हो जाती है ये लाइन. और ये चीज़ भी वो अच्छी नहीं लगती जब पिक्स वगैरह आती है ना. ये लैदा हो गई है और ये चीज़ लैदा हो गई है. 2 हिस्से हो गए.
It's really interesting because when I remember the first aesthetic course I did in the UK, that was back in, I think it was over 12 or 15 years ago, the indication was nasolabial. And in order to treat the nasolabial, they told us you take a needle, you inject it under the nostril, you give a bolus, and you treated the nasolabial. Later on, we realized this is not the right way of doing it, because let's go a step back. When fillers came up, dermatologists said it was our territory, plastic surgeons said it was our territory, dentists wanted it, GP wanted it, and then they called it anti-aging medicine, because that's what we're trying to do. So in order to treat it, we need to understand the aging process. So later on, we realized that the nasolabial fold forms not only because of loss of volume in the mid face, the mid third, it's because of the aging vector line. And research has shown that the aging vector line tissue moves this way, in a curved way. That's why plastic surgeons, when they take the patient to do a facelift, they don't pull the face backward, they don't pull the face upward, they do it backward and upward. So therefore, if you want to treat the face according to aging, what we need to do is start here and not inject the nasolabial itself, because otherwise everyone around town will be looking like that. So, and the first sign, for example, of jowling, of aging, is jowling. You see it in the late 30s, early 40s. That's not because the lower third aged the first, but it's because loss of volume here, loss of volume here, and loss of volume here, and everything starts falling down. But because of gravity, this is where everything ends. So with that in mind, what we're going to do is, I would personally prefer starting from the top and giving the temple area, and then injecting maybe the tear trough, and then having a look. Sometimes it's worth doing the zygoma as well, because with time, what happens is the zygoma, the curvature of it goes backward and becomes flat, and that's why you start losing the tissue. Personally, I'm a big fan of injecting as deep as possible whenever I can, because your filler is just doing one course out. So for the temple area is somewhere I would inject very deep on bone. The zygoma is, again, I would go deep with the respect of anatomical landmarks, because in certain areas we have to respect the anatomy and we can't go that deep. So for our lovely lady here, I think this is, again, what we're going to do is, I would like to, we could see the depression she has in the temporal fossa, so I would like to give a little bit of volume here, maybe give a little bit in this area, and then assess and see, and decide whether we need more, and the tear trough. The cheeks is a funny thing. I find it a funny area to treat, because it's very dynamic, and when I want to treat the cheek, I will need to think not only when the patient is static, is when the patient is smiling. Because at the moment, if I look at the cheek, I could see, yes, she has a little bit of volumous here, and I could inject in this area. But if I ask her to smile for me, if she smiles and I've injected, that's when you end up with an overfilled, and you get this, and you get exactly a smaller chipmunk. So therefore, whenever you want to assess the cheek, make sure you assess the cheek when the patient is still and when the patient is smiling. So let's take it step by step. Let's start off here, carry on down, move against the aging vector line, and then decide what we're going to do. I want you to try and feel the injection and the extrusion force. So whoever wants to come and put their gloves on, they're more than welcome. I would, in this area, I would go deep on bone. My landmarks are usually the same landmarks I use for the 3PF. What I usually do is I draw the orbital rim. I take 1 centimeter backwards. I draw the temporal crest, and the temporal crest is very easy to find. If you put your finger on your forehead, drop it, that's where the temporal crest is here. And I would draw where it drops here and here. And then I would take 1 centimeter from there upward down here, and that's where my point of entry is. And I'll go straight on bone and just give gunshot. The temporal fossa is like a swimming pool. So there's whenever you want to fill the swimming pool, it doesn't matter if you're filling it deep on bone or if you're filling this shallow or the deep part, as long as you fill it. But whenever we want to inject with the needle, we always need to think that we need to go through the least amount of tissue to avoid bruising. It's all about giving the patient a pleasant experience. We all know how to do nice lips, but the trick is to do it without pain and with minimal bruising, especially in this area where all the vessels and arteries are running out. So I'll just do one, and then you guys could carry on. Is that okay? Looking at which one I'm going to use. For the temple, for example, I would go for something, because it's going to go under the muscle, it's going to go under the temporalis muscle. I want something really to give me a nice big push. So that's why I'm going to use the extreme one. I'm going to use because I'm going to go straight on bone. Now, if you are to inject, I'm not here to say which is better and which is, I'm not here to debate.
Yes. This one is thickest.
Yeah.
Extreme viscous, most.
This is the most. This is how it looks. Right. So. Now, again, I find that temporal fossa is one of the most debatable areas or indications I find in the face, because there are two methods. You either inject superficially or you inject deep. Personally, I'm here to inject. I inject deep. In order to inject superficially, the safe plane is between the superficial and the deep temporal fascia. Personally, I could never get to that plane. I don't know. I know that in order to get to that plane, I'm a maxillofacial, and my subspecialty is trauma. And what we did a lot of temporal fractures, zygomatic fractures. Sorry. So in order to get to the zygomatic fracture, what we do is we have to slide something called a Gillis along the temporalis between the superficial and deep temporal fascia. And in order to get to that plane, we do our incision behind the hairline. So personally, I think this is the only way to get to that plane. And I find it a little bit uncomfortable, and I don't have a bone cannula. So as I said, I'm not here to say which is better, but personally I prefer injecting deep on bone. And when I want to inject, I go at 90 degrees at the point, and even though I know it's quite safe, but I would still poke my finger just to make sure there's nothing pulsating. Now we're happy with that. I go straight on bone, sharp scratch coming in, love. Once I've hit bone, I'm going to aspirate. An aspiration should last for 7 seconds at least. So 4, 5, 6, 7. Once we're happy with that, now I could slowly start injecting. Again, remember, part of what I do as well is deal with complications. So I've dealt with complications all around the world. And I could tell you very comfortably, 99.9% of the complications are because the doctor is injecting too quickly. As simple as that. There's something called the dilemma, where if a complication happens, the patient blames the doctor blames the product, and the product or the pharmaceutical company blames the patient, saying it was the wrong patient But 99% of the complications I've seen are because of the doctor technique, and 99% of them is because of speedy injections. There's a really interesting, open your eyes, love. There we go. There's a really interesting paper that looked at when do complications happen during the day, and at what syringe does it happen. What I mean is that a patient comes in requesting 5 syringes of fillers, when does a complication happen? And the complication happen at syringe number 3, and during the day it happens before lunch break and before going home. I promise, and I'm sure it happened to every single one of us. And it's all about speedy. Take your time, and even if you are in a vessel or an artery, it's different when you inject a 0.01 or a 0.2. And that's what saves the patient.
So are you injecting while talking?
Yeah, I'm injecting while talking, yeah. But I'm doing it very, very slowly.
Yeah.
So throughout what I've...
The question is, even if you do slowly, or even you do quickly, if you're in a vessel, you're in a vessel.
That is absolutely right. But if you're in a vessel, the first sign of intravascular injection is the patient's head hitting the wall because of pain. So if I do inject in a vessel and the patient feels that pain, dealing with a 0.01 bolus into a vessel is going to be much easier than dealing with a 0.2, especially when, so throughout the speaking I've been talking, I've given 0.2 So this is how slow. But I promise you, this is the lifesaver. And I know you guys are in a rush, and I know that this is not the way it happens in the clinic. But this is the way I've seen things going wrong that taught me. I've worked with an instructor in Dubai. That when we would be training some doctors, she would call them bulldozer doctors. And I'm sure we know some of them, because once you do that, if I have a 0.01 bolus inside a vessel, I will need much less hyaluronidase. Dissolving it's going to take quicker time. I've given 0.5 now. Now, always with a needle, as a rule of thumb, the one thing, if you are to take of me from this trip to Lahore, is doing it slowly and gently. Even when you go out very gently. Because looking at the face, 100% I went to a vessel or an artery. There's no way. A small, a big, I don't know, but I've been through. But when I'm pulling it very slowly, those layers are closing up. So the blood is not rushing. You know, we got to a point where we all know how to do lips, we all know how to inject, we all know how to push the plunger. It's time for us to think of how we can make it a pleasant experience to our patients. Injecting it slowly, with minimal bruising, minimal pain, no blood flushing backwards. Yeah? So we've done this. I've given 0.5. Who would like to do the zygoma?
Can I do
Yeah.
Of course, pop some gloves up and
Okay, tell me.
yeah.
Sir,
So what we're going to do, is we're going to do the right side of the face, sit her up to compare the right and the left and the. So I took 1 centimeter from the lateral orbital margin, okay, and I drew a line, and then I drew my temporal crest. Now, where that 1 centimeter, I drew a vertical line. Where it hit the temporal crest, I went back, and that's where I injected. Again. Let me draw it with a. Do it with a marker. Right. So, actually, can we see straight away the difference? This is the beauty of it. This is 0.
Yes, yes.
And remember, this is the temporal fossa, and this is 0.5 of hyaluronic acid, guys. Only 0.5. Look at the projection it gave me. So Maili patented the technique of removing the oxygen in order to give volume with less material.
And how long does it last?
It lasts a year, but
On
in
this
order
area.
to be very transparent,
10 months.
in order to be very transparent, okay, Maili is new on the market. Before people start eating me, Maili is new on the market. We all enjoy evidence-based medicine.
Yeah.
So far, this is what the evidence have shown us. We are confident that those are the right numbers. We always are trying to improve it, but so far, Maili stays. The lips one, reports and numbers have told us that it stays for a year. That's what research has shown. Okay. Again,
lip is the
lip is the most one that
yeah.
dissolve, but yeah. So that's why whenever we want to compare, because of muscle activity, the lip, the orbicularis, yeah, orbicularis oris is always on the go. So yeah.
So it's highly cross-linked? or-
It is highly cross-linked,
Must be.
very highly
Yeah.
cross-linked. Yeah. It's but again, the cross-linking is BDDE, the same as other lines. But the difference between this one and the other one is that the removal of the oxygen during, so the purity of it is much better. Please, I want you all to put some gloves on and have a feeling of when you're injecting it in the face and see.
Hello, how are you? I'm
I'm
Dr.
good.
Amna.
Very nice
Good
to
to
meet
see
you,
you.
Dr. Amna.
Thank you.
Sorry you were running a little bit late, but that's
Yes, I
because of
heard.
Emirates Airlines, not me.
That's fine. We're used to
The
it.
flight was delayed. Okay, right. So, I just start off by drawing the lateral orbital margin. I take 1 centimeter backward. Now it's time to think of the temporal crest. So in order to find the temporal crest, you just slide your finger where it drops, that's one. Where it drops up, that's another one. I draw a line, now I have my temporal crest. I'm going to draw a vertical line straight from the lateral orbit where the temporal crest meet. Now where they meet, I go back 1 centimeter, and that will be my point of injection. All right? Brilliant. So, as for the zygoma, when we were developing those points, it was all about giving the patient a pleasant experience with minimal bruising points. So, we tried finding a point for each third that covers all the indications. So we found this point where from this point you could go straight onto the bone, and even if you want to do the eyebrows, if you want to go all the way to the forehead, that works. For the mid-face, we take 1 centimeter inferior to the lateral orbital canthus. And that's pretty much the point. From this point, I could go with a cannula and give the zygoma. I could go to the tear trough as well. I could fan the cheek if needed, and I could go all the way down to the nasolabial and give a bolus if needed. So it's one point that covers all areas. Now, you could inject, at the end of the day, if a patient just wants a nasolabial, I would go in. But the whole point is minimizing the points of entry for the patient in order to minimize the chance of bruising and pain. Okay? So if you don't mind, whoever's going to do this one, we could go from this point with a cannula all the way backward, and we could inject over the zygoma. How does that sound? Is that okay? Cool. So let's carry on with the extreme. Absolutely.
So you're going to go around zygoma, isn't it, with that?
Yeah. So what I would do is
सर को दोबारा सर कहना पड़ेगा सर भी कह रही है सर भी ये भी सर का सर करते से पका
so.
Thank you.
I'm not going to give a bolus. Never a bolus at this point, because you're going to end up with projection. So this is a point of entry. And what we're going to do is we're going to go all the way backwards.
Excuse me, ma'am. आपको को कैमरे के बिल्कुल perfect आ गया.
So we can go to the temple.
It's very small.
No, I would prefer a needle because it's going to be hard with a cannula.
Needle would be easy.
Yeah.
No, not me.
थोड़ा सा मोबाइल
Very small.
थोड़ा
I think we need a bigger.
Yeah, hole. There we go.
Bigger
Now you can see it
hole.
now. There we
Yeah.
Yeah.
What is the depth now?
On bone, as deep as you can.
Okay.
And
Do you touch the bone while
go. No, you can't.
if I can, but I think you see, the masseter
yeah.
it originates from the zygoma, and do you feel the?
Yeah, it's very soft.
It's very soft, but this is volume again, so it just gives so.
Yeah.
Fine.
Oh my God. Relax. Deep breathe कर ले, लंबा सांस ले,
breathe in and
लंबा
out.
सांस ले.
Dear soft.
उर्दू ज़बान में
Very
बात
small.
इतना तो समझ आ रही है क्या नहीं आ
Soft.
रही तेरा मीन बहुत सॉफ्ट मीन सॉफ्ट इतना से समझ आ रही.
Rami,
Yes, sir.
what do you think?
So I think what I would do, I would go straight
A bit
on.
more?
There we go. Sorry, love. And then as I'm pulling out slowly, I put my finger to feel the filler.
Yeah.
Yeah.
And as I'm pulling out, that's my tip. So you can
So-
carry on.
So.
So yeah, just like that, yeah.
I see in this shot.
You know what I mean? So you feel the filler pushing.
Yeah.
as you're putting out. And the minute you reach here, you stop, and then let's go in and give another one. A bit more.
Okay.
Yeah. So now we're happy.
1.5.
Yeah. We give it a nice massage. Make sure nothing's bumpy. And let's have a look at how her face now is contoured. You want to sit up for me, love?
ये बैठेंगे please. लड़कियों आगे से कैसा है?
फोटो
I'm going to use the thinnest one.
Look here. Can I see?
in this area.
Yeah. I'll tell you why. The fact that we manipulated a lot here, this is swollen at the moment. So because it's swollen, it's giving us that depression. Once the swelling goes down, it will be fine. So for the tear trough, in order to avoid Tyndall effects, we need to inject our filler under the muscle. Now, hyaluronic acid in general works like a sponge, so it absorbs water. So therefore, the way the tear, always underachieve with tear troughs. So always give 20% less. The second thing is, the way it should look underneath the muscle is like that. And that's how you avoid the Tyndall effect. Little aliquots. Because even though the patient is going to leave your clinic thinking she needs more, in 48 to 72 hours, that hyaluronic acid is going to absorb water and it will look nicer. If you achieve 100% of your indication straight away, what's going to happen is the patient's going to look fantastic. The photo for your Instagram is going to look very good as well, but the patient's going to come back in 3 days saying you need to dissolve something. And to me, the worst thing is when I need to me, hyaluronidase in the clinic is only for intravascular occlusion. It's not for dissolving filler. Because once we start going into the cycle of dissolving and filling and dissolving and filling, especially under the eye, there's no end of it, because it will dissolve your normal hyaluronic acid tissue as well. And have you ever tried injecting hyaluronidase? It's such a painful procedure even for the patient. And today, as I said, we at this point of all of our careers and at time, we're not here to talk about how to inject. We're here to say how to give our patient a pleasant experience and make sure they leave our clinics happy. If you start injecting hyaluronidase right, left, and center, that patient is never coming back. I promise you. And she's going to tell all her friends about you as well. So what I do is,
Go to the same point.
same point, I try and squeezing it through the orbicularis oculi muscle. Now it's sliding onto bone, and I push it. So just for teaching purposes, this is how the cannula would look when it's under the muscle. And I'm going to pull back again, and this is how a cannula would look if you're superficial. All right, sorry, love. Go in. Straight on. Sorry, love. Very sorry. Now, see, I could barely see the, and that is exactly where you need to go. But I could feel it where I am. And now I'm going to start giving little. Now look at the movement here, motion.
It's the same thick filler, right?
This is the very thin one now.
A thin one.
Yeah.
Okay.
I'm very, and you could feel. Yeah. And as a rule of thumb, in my practice, for a first visit, I never give more than 0.3 for the first visit, for the tear trough. Okay? So, let me see the, yeah?
I have
Okay.
a question, please.
Yes, please.
What was the medial most limit? I'm sorry. What was the medial most limit?
It's all about, we all know anatomy. We all know that there's a facial artery coming here. We all know that it goes. We all know that it splits. We all know that over here we've got the angular and the lateral nasal artery, right? But when you're injecting, what's important is depth. That's what we need to know. How deep it is, and accordingly we decide whether to inject superficial to it or deeper. Now, I know that, for example, the supratrochlear goes up and in the upper 2/3 it's over the muscle. So I know straight away I'm going to inject under the muscle because the artery is over the muscle. Over here, I know I have the lateral and the angular arteries that run around the nostril and start going around. Now, is it superficial or deep? I don't care, because the thickness here is so slim that you won't be able to go superficial or deep to it. So therefore, this is a no-go zone. So our danger area in this area is the angle between the nose, it's called the nasofacial angle, so over here. So after here, you don't inject. Before here, you do inject. I get asked this question a lot, but sometimes we have depression here.
Yes, correct. Yeah. And most of the time it's there.
Well, we don't do it. Let's understand the limitation of everything we do. If you have a hammer, not everything is a nail. So instead of injecting it, what you find is, what you could do is inject under the muscle. When you're doing the aliquots, that is going to raise the whole muscle. We did a research at one point where I'm not sure if you're aware of the perfecta, so I was using subskin perfecta. Subskin perfecta, those particles, I mean, if I hold it and throw it at someone, it could open someone's, it's really thick. And at one point, what we were doing is placing 3 aliquots only under the muscle. And we were getting results because we are placing it under the muscle. Let's, think of the anatomy of it. What caused the tear trough? The tear trough was caused because of the loss of deep fat. So in order to replace that and treat it, we need to replace the deep fat. Deep fat is present under the orbicularis oculi. So therefore we need to find a product that goes under the orbicularis oculi and raise it. Now that's if we're talking about tear troughs because of aging. So the hollowness over here that happened is not because of superficial fat loss, it's because of deep fat loss. So therefore we go deep under the muscle, place our fillers there, that's going to raise the muscle and we're going to get results. If that doesn't work, we need to think of a completely different treatment. Maybe think of surgery, but just because you have a filler doesn't mean you have to inject it here. Does that make sense? Right.
In some people, the skin is very thin in the under eye area, and the bone is quite visible. The muscle is also very thin. Placing the thin filler, most of the time, it just get.
I promise you, always inject under the muscle. If you always inject under the muscle, you'll be okay.
What to do when the skin is very thin?
Minimal amounts. If you think,
then it starts showing up.
Then don't do fillers. The fillers is not for choice.
What is the alternative? Fat?
I'm not a big fan of fat injection personally, and I don't do it in my clinic. But I know of injectors who do fat injection, and they end up with fantastic results. Personally, I don't like fat because the results are unpredictable.
And
Can
what
we do
about
it
the
with a needle?
thick fillers?
Can we do it
Under
with
eye
a
area, a little voluminous filler with bolus with the needles. There are
Okay, so again, when we see complications, I think whenever you're using a needle, there's a big chance of bruising. This is number one, right? So I promise you, if you do it with a needle and the patient comes back with a black eye, the doctor in the clinic opposite your street is going to be able to do it without a black eye. And she's going to do. Am I right or wrong?
Yeah, that's true.
At the end of the day. And as a patient, we're not doing open heart surgery. A patient wants to have her fillers done, leave, go for lunch, go for work afternoon, and go for her dinner in the evening. She doesn't want to stay at home for 3 days for under eye fillers. So the answer is, can I do it with a needle? Of course you can do it with a needle. Absolutely.
but then bruising is a possible.
Cannulas are newer. When fillers came, it was only needles. But are we looking, again, pleasant experience? Think of the patients now. If you look at how conferences worked when it comes to anti-aging, when it first started, they were all talking about technique. You take this, you inject it, right? Later on, they realized they were getting a lot of complications. They just started talking, you know what? Let's talk about how to deal with complications. Today's conferences is all about anatomy, because they realize that we need to think of what caused the problem and then accordingly treatment plan it the right way. All right?
That's true.
Okay, let's sit her up and see the difference. Now, when she first came in, the main problem, the first thing she pointed was the nasolabial. So what we did, we placed 0.5 here, we placed 0.5 here, so that's 1 mil, and we placed around 0.2 in the tear trough. So at the moment, she has 1.2 of hyaluronic acid in her upper third. So let's see the difference in the nasolabial. Do you mind sitting up for me? Between the right and left. Yeah?
Yeah, there
A
is.
bit of improvement?
Yes.
आपको लग रही है bro?
Okay.
Yes or no?
Yes, yes.
Subtle movement.
There is.
Okay. So, what are we going to do after? Do you think this is enough for her? Look at the tear trough. I love the tear trough.
Yeah, it's
Yeah?
better.
So, shall we do the left side now? Yeah? Because I'm looking at her angle. She has a very nice sharp angle. Yeah? Do you want to put some of? Yeah? So, how would you like to see it? Would you like to go deep or would you like to go superficial? Yeah? Okay, so there are two ways when injecting here.
ये हो जाएगा.
You
ये
either
हो जाएगा.
you either inject deep on the periform or superficial. Why? Because the angular artery runs in the middle. Okay? So you fancy doing it superficial, the point of entry is going to be here, and I'm going to fan it. What material I'm going to use? I'm not going to use something too flowy, and I don't want something too strong, so let's go for something in the middle.
वैसे नहीं नहीं रूम से बदल के आना चाहिए
So we're going
रोम से
to
बदल के आ गया क्या
Fine.
हमारी मॉडल के साथ
So, sorry, someone's being a drama queen today. What I'm going to do
आपके मुताबिक नहीं कह रहा
You're
हूँ.
using medium or extreme?
now I'm using the define, which is
Define.
not precise, not
Too
very
flowy,
thin, not too
but
flowy, but
it's number two.
It's number 2, exactly.
Okay.
And what I'm going to do is subdermal.
Yes.
See where I am?
Yeah.
Oh, come on, it's not that painful. And then, so who wanted me to do the nasolabial? You? So go ahead. And I just want you to feel the pressure of injecting. It's just such a nice feeling where you don't have any hiccups in it. And as you're pulling out,
slow let's slow
Subdermal.
it
हाँ,
so can you give another one here?
Yeah.
Brilliant.
Yeah.
That's fine.
Better.
That looks really better, actually. Good call. Sit up.
इसका यही कंसर्न था अब
Yeah.
देखें अपना शीशा
I'm taking.
क्या बात है
मैं भी
So who's going to do the left side? Who wants to do the temporal fossa on the left side?
ये हो जाएगा.
हाँ चलें
Can we see a hand?
आजा आजा
Go on.
इधर तक ही
दो
करना
कपड़े आप डालेंगे.
Sorry, excuse me. Open it.
इसके थोड़ा सा बड़े से लग जाएगा. हाँ. तो फिर ये जरा deep with the needle. Deep with the needle.
डीप क्रॉस खत्म हो जाएगी
चली गई.
Okay. So do you want to do your outlines first?
You know,
Yeah.
I can feel the rest.
Okay. That's pretty much pretty much where it is, and then you press anything palpating. Cool.
Why not here? I feel a dip over here. Why not here?
You feel, well, this is again when we did it, we were looking at anatomical landmarks at
Yeah.
safe zones,
Yeah.
and we realized that this is the safest zone as far as when it comes to the superficial and deep temporal arteries. So that's why we
Here.
said it, yeah. But yeah, I mean, at the end of the day, if I put my point and I feel something palpating,
Yeah.
then I'm going to go up above. So it's not it's not like this is the
rule
the rule.
varies every person 15 मिनट में डालना है आपने
So we're going to go in on bone. We're going to aspirate for 7 seconds first.
4 minutes. So here.
Yep. What I want you to do is go here, so straight onto bone. Bone, 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 bone. Now we've hit bone. So aspirate for 7
Bone है
seconds.
नीचे.
yes
1,
ऊपर फोसा है ना.
2,
इधर चला जाता है.
3, 4, 5, 6, 7. Now, slowly.
So keep talking.
You can talk with us.
How are you feeling?
Talk with
How are
us.
you feeling while interacting?
Ask the patient, are you comfortable?
Yeah, and I always ask the patient to open their eyes.
Yes.
Open. Ask खोल ले. Numbers last name.
Swami, is the needle primed or unprimed? That's not the question.
This is prime.
Okay.
Yeah.
So do we keep a finger over here as
You
well?
can. There's no harm. But here's again. So the swimming pool, it's the temporal fossa is like a swimming pool. Even if you try, the filler is not going to go out. If you really try, I mean, you'll need one of those 10 ml butt fillers in order to get it to overflow. But I do agree with you. Maybe placing your finger will give you the tactile sensation of the tissue going up. So okay. So what?
So if you put little filler in that,
It will raise it.
will it?
Personally, what I do is I just fill under the eyebrow.
Doesn't make it masculine. Thick.
It's all about the material you use, the amount you use. So, I mean, if you go with something really thick, yeah. Now we're going to pull out very.
A bit is left.
A bit is left. Okay, finish it.
मेरी एक तस्वीर तो खींच
क्या बात है? Correct.
अभी निकाल नहीं अभी आपने निकाल नहीं
She wants a picture with that, so she is not pulling it out.
Ready?
Yeah, we should do this one for picture. Not a good idea.
आपने मेरी खींची थी जब मैंने गाड़ी So I'll be slow in taking it out.
Very slowly.
It's okay, press
So,
Press.
it's your pressure was fantastic. Your pulling out was too quick. Take it very slowly. So again, what you're doing is when you go deep on bone, 100% you went through arteries and vessels. But when you're pulling out, you pull out and you allow the layers to close. And then you pull out a little bit and stop. And then pull out a little more and it closes and it closes. If you pull out suddenly, the blood is going to flush back behind it.
I had a problem where I wanted to inject on the bone when I was removing the needle. Then I had a gush of blood in the needle. So needle can be very much tricky because you go through the blood vessel. You go through the blood vessel. You're under the blood vessel. So you have to stop injecting.
Filler with Canada.
And then.
So who's going to do the zygoma now? You're going to do the zygoma. Fantastic. And we have volume on a camera.
1 centimeter below the
Lateral canthus. Because what you'll see is, as I said,
1 centimeter.
more or less it is. But at the end of the day, when you go from this way, if you're using a cannula, you go all the way back from here, and the same cannula you could use it here, so you don't have to play meat.
Dr. Galadari of Dubai.
Oh, okay.
He has invented a point.
Call it the RH.
It's not.
यार क्या वो देते हैं
खूबसूरती के लिए बड़े बड़े
ऐसा तब कह दिया कि मुझे टिप्स भी चाहिए.
और
Needle, the cannula ends.
This already.
No, really. It's about 26,
25?
25, 26. Very, very
25.
Yeah.
I hate it.
थोड़ा सा और कर लो
Please don't.
It's bend over. Bend over. इसका भी उसको
Do you want a new cannula?
No, I'm okay with it.
You sure?
Yeah.
टेढ़ा होगा
So here's a trick when you want and just manipulate it till it goes in. So just try manipulating, playing around it.
This is for female.
ये देखो यहाँ से भी bend हो रहा है ना.
हाँ bend हो रहा है कैनुला चेंज कर लो
Focus on the lower leg for males in order to increase the length.
and this is
pull.
I don't usually give that much over here. I would give more anterior projection.
so we're gonna take this direction
Yes.
कितना देना है यहाँ पे
0. How much did we give on the other side?
Just 0.5 to just finish it if you want.
Okay. Drag it here. So keep on fanning over here, right?
on the ball
Not fanning, giving a tunneling, I would call
Okay.
it.
To be honest, I don't like the bolus either here. A lot of people do 3 boluses and most patients get pain.
Yeah.
With this, it's pretty painless. Not painless.
static others are also good.
Yes, yes.
Are you guys using Elance?
Yeah.
Yes.
Are you combining Elance with hyaluronic acid?
Yes.
How would you choose? How would you choose? Here's a piece of advice, and let me know next time when I see you in Paris or whenever the next one.
In class?
Wherever I see
I
you.
will be there, but I don't know about the rest.
Depends who use Elance or not. No, but
I don't know who has the visa.
So
आपका visa है? इनका तक नहीं है, मेरा 2nd February तक है.
here's what I want you guys to do. This is a personal favor. What I want you guys to do is, next time you're combining treatments between Elance and hyaluronic acid, you know the ligament lines, right? Behind the ligament lines use Elance, and in front of the ligament lines use hyaluronic acid. Look at the results though. Tell me what you think.
Okay.
All right?
इनको यहाँ भी और भी ज़रूरत है या शायद ये swelling है इसलिए we had a swelling over here, huh? We had swelling here, so there's a
First time we
It's new. It's the non-first.
I mean, who hasn't injected today, Maili? So I want to make sure that everyone injects Maili today. You like it?
yes
Do you want to see me doing it? Yeah? Okay.
because I think that would be good.
Yeah? Okay. Let's do the teardrop and then we'll come back. Go as deep as you can.
Is the lidocaine in this?
cream coming.
But this is another thing. If you inject if you want to inject lidocaine in the point of entry.
No, I'm just asking, do we have something in the filler?
Oh yes. Sorry. 0.3 of it is lidocaine.
That's
Yeah.
what I was asking. Okay.
0.3 of it.
So for her, we need
We use 1 point.
one on the cheek, one on his cheek,
But we use
0.5 here.
So yeah, we use about 4 for her face, but then she wants her lips done, so it's 5.
मुझे लगता है
Point three
हमें
मिली का
इंश्योरेंस
डाला।
लॉन्च करनी पड़ेगी। नहीं, ठीक है, हम फिर वन बाय वन नहीं कर सकते।
हमारे मरीज स्टेप वाइज आके कराते हैं no superior is
So how much is
Point नहीं चाहते सर do you think I can say anything to me? Come on.
Never cross the nasofacial angle. Never.
You always learn something.
And I do blending.
Always learn.
Yes.
I inject bolus and then I do blending with Q-tips and then I spread it till there and fix it. Is it
That's
fine
why
to
we
do
need to
that?
go and look at those
But
what
very
therapy,
thin
see what they are doing.
The problem is you have the lateral nasal artery here. The lateral nasal artery sometimes, like for example in her case, look where it is. You can see it straight away. So it's not only intravascular. It's not only intravascular. It's occlusion. It's pressure over it as well. So personally, I would avoid that.
Because most of the time patients come up again with the complaint that we have got dipole. So what I do, I inject a little bit on this side with the cannula and then I blend it with Q.
Beautiful.
Well done. Yeah.
Beautiful. Right. So who's going to do now the nasolabial?
चलो सानिया कमर
कर सकते हैं लेकिन यहाँ से मुश्किल है यहाँ
ये
से
देखो ये एंट्री पॉइंट ये एंट्री पॉइंट यहाँ से देखो हाँ in the direction of the fold yes बस देर तक
Are we going to do the lips with the cannula as well?
No, with a needle.
this one it was this one
Define.
yes
And if we have precise nose, then again with the cannula. Doctor needing
Sorry?
to shot.
वो ये कौन सा है तुम्हारे
With the
हाथ
cannula.
Precise है, I need
Define
to define. Take the entry point.
तो डिफाइन नहीं देना
नहीं,
precise
define
नहीं, define दे.
यहाँ डिफाइन डाला था
Yes.
Define thin है. Which one do we use here? Which one do we use here? Define. ये है ना? हाँ. Defined ऊपर वाला जो है ना उसमें मैंने डॉक्टर हाँ जी वो इधर ठीक रहेगा. Define thin है. थोड़ा सा deep होना चाहिए.
But you know when you make a port now, so make it like in the direction of the cannula. You don't make it at the right angle. So that's this pressure stretch.
Push.
I am following you
cannula
this
को आपका
point,
glove
and I'm getting amazing results
Yeah?
for under eye.
Glad to hear that.
And it has made my life
मैंने सही है.
anything.
It's just makes Play with it. Play with it. And you'll it'll eventually go where you want it.
But try doing it because
Sorry.
Hold it like a dog. Okay.
बस बच्चे हो गया. It's done.
There you go. Now you can move up. Manipulate. I try to use a large.
0.5. 0.5. Slow. पहले जाओ.
What I want you to do is here's the movement.
And come
Give
down.
as you're pulling out.
Yeah, very good. That's it. That's it.
Stop.
Slow.
Again. Give as you're pulling out. Do you see how smooth it is to inject? Yeah?
डालती जाओ जहाँ तुम्हें मुनासिब लगता है. According to the, you can compare it to with the other side. You've done it.
I do it with
Just finish
25
it.
days.
Finish the whole syringe.
तो मेरे पास एक मतलब कैनला फिनिश हो गया तो I tried it with 23 days. Very easy.
Now this way. The bigger the size.
Down, pull and come down. ठीक है? And then अब दोबारा आ गई ना. आपके पास रह गया ना 0.2 रह गया खत्म हो
ये
गया.
सारा डाल दो. इसको खत्म.
Yeah?
इसके एंगल
Right.
देते हैं.
Don't touch the
Shall we do the lips?
infect हो
But you promise you won't scream, yeah?
problem.
नहीं वहाँ से ना दिए.
Okay, fine.
दवा अच्छी प्लीज.
चलेगा
क्या
टेक अ
equal होगा?
नहीं लगा
Equal होगी. थोड़ा सा मैं ये कर देता हूँ इससे.
सनिया तुम्हें कौन नहीं पहचानेगा
हाँ,
मास्क में
जाहिर
मास्क
बात।
के बगैर.
मैंने नहीं पहचाना
एक ही
इसको।
स्टैंडर्ड
इसको
साइज
मैंने
है
नहीं पहचाना।
सनिया का. अच्छा really?
हाँ।
Oh, that's a surprise.
हम तो नेबर्स हैं। हम नेबर्स हैं।
फिर भी आपने नहीं पहचाना.
ना
बड़े अफसोस की बात
मिली नहीं है
I
मुझे
don't like
इतने अरसे से नहीं मिला करती.
भूल गए 2 साल में.
और क्या?
तो 2 साल पहले भी आप ऐसी ही.
सनिया सालों से ऐसी है.
हाँ मैं फर्स्ट टाइम आई सॉ इन कोयटा फैट तब से ऐसी की सारी की सारी.
First time I saw her couple of years in America and
काफी
I
thick है.
thought she's the matrix student.
Very difficult to inject. I found define. Extreme would be more thicker than this one, isn't it?
Absolutely, yeah.
Yeah, even this is quite thick.
It has more
Right.
repetition.
No, no, extreme. I define.
Define, okay.
So when I first started learning about lips and how to do lips, I would split the lips into 3/3. I would give the outer third less amount than the middle third, right? Then I realized this is not the right way of doing it, because what I realized was what patient looked absolutely fine when the patient was static, but the minute she smiled, this is how the patient looked, because the auricularis oculi or oris is a constrictor muscle. We use it quite a lot. We use it eating, speaking. So what I then realized is that all you need to do is volumize the middle third, and that will give you the nice pouch you want. You'll need less material, but you'll still have better results. Then the Russians came up with something called the Russian lips.
They mostly have implants in the lips.
Yeah, which is fine. I understand beauty is very subjective, and we have patients who request it.
Ingoing angles, they're drooping angles.
Okay.
And then they want this to
Cool.
come out. And
So-
they want when they smile, their smile should be pulled up smile.
So what you're saying is the sad smile, right?
It's that some, and some
Yeah.
people have like this
Lots of
is more
volume,
projected, and
Yeah.
they don't have volume here.
Okay.
There
So
are
here's
people.
yeah, I know. But we need to think again. Let's start off by talking about the sad smile, and then we talk about the
Okay.
other thing. So the sad smile is when the corners of the mouth drops downwards. But this is part because again it's something dynamic. So if we fill to the right amount, the patient smiles, you're going to end up with the bolus popping out. What caused the marionette? The marionette has been is caused by 3 different factors. Factor number 1, muscle activity. So the muscle, DAO is pulling it downwards. This is number 1. Number 2, loss of volume. What do I mean by loss of volume? With time we lose volume, tissue. But the
Loss of bone
tissue,
here.
no, there is no bone. This is tissue. Yeah. So the tissue here, thickness is different than the tissue behind it. So therefore, when you lose the volume, they don't lose it equally. They lose it in a different way. Okay? So they lose it separately. They both lose volume, but in a separate degree. So we have number 1 so far, the DAO, muscle. Number 2 is the loss of volume. And number 3 is the tissue movement, the aging vector line. So in order to treat the marionette the right way, you have to approach and treat all 3 factors. Muscle, treated with botulinum toxin, volume loss, treated with fillers, and the tissue with threads. All right? So this is when it comes to the sad smile that is part of the marionette. But what about what you said, when the patient doesn't have any volume here? Then yes, maybe you could add a little bit of volume, but be very, very, very careful of how much you add, because the last thing you want is for the patient's lips to go this way when you inject them. Right? Right, so let's inject the lips now.
I have prescription.
Tried any chin to treat.
Then it helps.
Thank you. Dry area. Yep. Side. And I start giving 1, 2, 3. So the way the filler looks inside is 1, 2, 3. Okay? And I stop at the vermilion border. So I've given the right side. Then I don't think you could ever do lips without defining them. You have to do volumizing and defining. Let's do the other side. And I'm just focusing on the middle third here. Here's 1, 2, 3. 1, 2, 3. We already started getting a little bit of volume now. Yeah?
Yes.
Yeah?
Very nice.
Now, now here's I'll tell you how we're going to do that. Let's finish the volumization first. 1, 2, 3.
Nami, what's the depth? Is it subtle?
Over the muscle.
Over the muscle.
As long as you're over the muscle, doesn't matter. And then, sorry. Now, again, when I'm defining, which is what you were after, I define the middle third only. So I go under the vermilion border. This is where I am. I hold the needle between my 2 fingers and I give a tunnel as I'm pulling out. Same is going to, see, so I've achieved what I wanted. But the secret of a successful lip lift, I'll tell you, follow the same cupid bow she has, never try and draw something else.
Yeah, it looks so beautiful.
It's very nice.
Very nice.
कितनी टेम्पटेशन हो रही है ना।
अब तो मैं भी सोच रही हूँ मैं भी करवा लूँ।
मेरा काम है मैं लिप्स में फिलर लगवाना है।
मैं सोच रही हूँ चेंज कर
All the ladies are interested in.
Sorry?
Yeah.
We all want lip fillers.
You all want lip fillers now?
We have more models here.
No, we want it on ourselves. No on models.
So do you do
Now,
these lines as
yes.
well?
Anyone
So,
want?
the secret of a successful
Have a
lip,
seat.
I find, everything we do in the face is about how the light hits and how the shadows are, right? So the secret of a successful lip, I find, is those 2 vermilion, those 2 filtrums. So I follow the filtrum I have itself as well. So look at the lip now, how it is.
Beautiful.
All right.
So
Look what's going to happen, how beautiful it's going to even look more when I draw
Yes.
those 2. There's 1 again between my fingers.
This gives the best lift
It gives you a nice lift.
and a very natural
Yeah.
look.
Now, So
Fantastic.
yeah. However, what I find is, you know, when you have a tent, right? And you put 2 poles in the tent in order to lift it up. So the same go for the lid, and that's what they call, and that's what they call the pillar. And just give 1 up, all right, and again 1 up. Look what we have now. Boom. Straight away.
बहुत अच्छी
For the lower, I'm going to do the same, but for the lower, rather than 2, I'm going to do 3, again at 90 degrees. Here's 1, 2, 3. Use a material you trust. Use a material that has something called the spring effect as well. The spring effect, you don't only need the spring vertical, you need the spring horizontal. So regardless how you move the material, it was going to go back. And that's why when it comes with such an active muscle, yep. Now you're going to find a new husband.
Now you're going to find a few husbands.
Yes, my dear. I promise you, no. Because if you want for teaching purposes, I would do it, but it's going to look very ugly. Never, I promise you, don't give on the upper third.
And the
Because
smile
it will look
spread.
it will look nice as the patient's sitting like that. But the minute the patient is going to smile, it's going to look like that. Because it's only physics. Orbicularis oculi is a constrictor. It's going to push everything outwards. So it's nice to push everything out to the middle because it will give us a pout. It won't look nice when you give everything on the sides. Yeah? Congratulations. Thank you.
Thank you.
Right.
The jawline.
The jawline. Okay, because I know this is a no-go zone.
Which one?
The jowling.
Okay.
There are a few fat pads. There are 2 fat pads in the face that has a tendency to. So I know straight away this is an area I don't inject. All right. So I either inject behind it, or I inject in front of it, but never in this area.
And then you get that.
Do you want to pull it out? Yeah. Thank you. So
you will be on the bone or
okay, so
like
here
it's superficial.
No, I'm superficial to the masseter. You will never be able to go with the cannula under the masseter. And another reason I don't want to go under the masseter because if the masseter starts rubbing against the hyaluronic acid, it will go quicker. So I want it just over the masseter, and all I'm going to do is just give it a bit of fanning.
You're touching the marionette lines as well?
I'm not touching the marionette lines. This is my point of entry. I'm placing my fingers here, and this is what I'm doing.
Angle.
All right. Now, if I want to, so here's how just.
Yeah.
Yeah.
Yes.
Very nice.
Again,
So you fan a bit there.
just fan.
Okay.
He has entered from here. Can you enter from here as well?
You can.
1 centimeter
You can.
above this.
Yeah, some people do
And
that.
then
I'm
वो
just,
जब दोनों
yeah.
कर रहे हो ना अपने
एंगल भी करना ये भी फिर से
Right?
लेकिन वो low
You just
होएगा।
entered
My
to
point
this.
of entry was there.
Okay, and you placed it on the goni and okay.
Okay. So who's going to do the other side?
Do this area also.
I will. But let's finish this on the other side, and then we'll do.
Okay.
So who wants to do the? Yep.
Yeah, sure.
Where's the needle opener? Yep.
मतलब सब जगह look है.
हाँ हाँ ये वाला jaw को define करना थोड़ा फिशल है।
अब अच्छा लग रहा है ना
Cute. इनके concern ये है.
इनके लिप्स कितने अच्छे लग रहे हैं लिप्स से ना एक आपके फेस में जान पड़ गई बहुत अच्छा लग रहा है एक्सीलेंट
Beautiful.
Sharp scratch. Bas. Listen, be careful. थोड़ा सा मेरी तरफ देखिएगा. Thank you.
मुझे लगता है कि अगर ये पीछे से डालता तो ज़्यादा अच्छा होता। दैट इज़ वी आर मोर कंफर्टेबल, क्योंकि वो इसमें तो जॉल में घुसने के बड़े चांसेस हैं। सर आप इसको पीछे देंगे और सॉरी डॉक्टर का
चश्मा उतारेंगे आप कहना फिलहाल सर कैसे?
हाँ जब चश्मे के साथ।
I want to feel your cannula when you're there. Please let me know.
मुझे भी फील करना।
You can't feel it, should be deep.
आप इसको स्विच करें जैसे मेरा
You won't go as deep as you can.
Yeah.
Okay.
It will never go through the mask. No way.
It's been a long time.
मैं एक पे गई थी तो मैं अच्छा इंसर्ट हो रहा है।
That was more than 2 years. That was must be 4 years. It's over the mask. है ना? हाँ. Lovely scene. कौन सा लेफ्ट सीखेंगे?
चला गया थोड़ा आगे पुश करें।
That's fine.
I would use something like precise. I wouldn't. Precise or defined, not extreme nor volume. I would never inject the area.
So I haven't injected a single once when I saw you last time, and you said you've seen so many different recruiters from Pakistan as well. I don't inject them.
I think I've seen a couple in Pakistan.
Yeah, because
I'll have
last
to
time
deal
I
with a
saw you
couple.
was in December,
Okay.
and you said never to inject them, so I stopped injecting you.
Okay, so for this area, I'm just going to go in straight on bone. So not on the fat pad. I'm just going to start off by aspirating.
Giving
one.
underneath the DAO.
वो तो डिफाइन कर
नहीं ये एरिया पे कुछ नहीं
है ना, टेलर करेंगे
इधर बोन होती है।
ये बेसिकली चिन लिफ्ट
Now again here.
नहीं नहीं प्री सर्कस जॉ लाइन में आता है, प्री सर्कस जॉ लाइन।
छह मुश्किल लगा बेसिकली।
अब नाउ हर कंसर्न इज एड्रेस्ड।
She was worried about that.
दोबारा
कम से कम 4-5 मिल गए उनके अंदर, how much it would cost आम हालात में तो
There you go.
I know, very nice.
Congratulations.
Now अब आप देखिए अपना, ठीक है?
अच्छा अभी आपको ना थोड़ी सी लंबी मंकी एंड ऑल दैट बिकॉज़ इतनी ज़्यादा मैनिपुलेशन हुई है टिश्यू की। 3-4 दिन में it absorbs a little more water and it's going to be perfect.
Eventually 2 हफ्ते में you will see final results.
2 हफ्ते लगेंगे, ठीक है?
Settle होने में।
एग्जैक्ट सेटल होने में।
लिफ्ट आने में।
लिफ्ट तो देखिए अपन।
लिफ्ट
को
को
देखिए।
बहुत बुरे
नहीं वो नहीं है, लेकिन ये नेचुरल, हाउ नेचुरल, या वेरी नेचुरल।
उनको जिन्होंने किया वो भी इधर पहुंचा।
हाँ तो हट गई थी।
मैं तो ऐसी चीज़ सोचती
हाँ बिल्कुल।
नहीं आपके तो हाथ है, पर आपने ये ज़्यादा अच्छा किया। आपने ये ज़्यादा अच्छा किया। टेम्पल भी नहीं। फिर से इसके लिफ्ट आ जाएगा। आएगा इसमें। आप टेम्पल पे किया ना।
लिप्स का आपने बनाया था?
So for a cheer trough, I would use precise. For a temple, I would use extreme. In the middle, I would use those two. Okay?
So in the temple you want to use extreme?
I want to use extreme. I want to go big, big.